I'd like to welcome Josh Mailman to the podium, and we're going to hear more from Josh later, but I'll give his mini bio right now. He is the president of the NorCal Carcinoid community. That's the Northern California support group for neuroendocrine cancer. He's also highly involved in nuclear medicine and is the chairperson of the Patient Advocacy Advisory Board for the Society of Nuclear Medicine and Molecular Imaging. Please welcome Josh Mailman.
And actually, I'm not speaking, so it's really good. So a couple of quick notes. We're about to switch into something near and dear to my heart, which is nuclear medicine, molecular imaging, and just imaging in general. And earlier in the day when Giovanna kicked off this conference, one of the things she said is you might learn something here that might change your life. And 2008, I sat pretty much in the same room you are, except it was in Toronto, Canada, and I was at a two-day neuroendocrine tumor conference by CNETS in Canada, and I hope they're online today as well. And I heard a lecture from what we're about to hear, people from Europe, Germans, Austrians, Italians, who came over to speak in that conference about nuclear medicine, molecular imaging, and something pretty brand new at that point, which is a gallium-68 generator and imaging that they were just doing. And little did I know, within 4 months, I would be having imaging with gallium-68 and further on have PRRT. So this is really something which can and will change people in this audience life. And so it's really with great pleasure that I'm going to introduce a bunch of our European friends, but first with Dr. Auerbach from UCLA, who is the general nuclear medicine PET-CT, and he really is studying, and yesterday I was at UCLA actually working in nuclear medicine or having a visit with them, and they're really working to investigate the role of molecular imaging PET-CTs in understanding the insights of our disease and how to actually manage and track our disease treatment. So without further ado, I'll bring up Dr. Auerbach and open this session on PRRT and molecular imaging.
Thank you, Josh. It actually says general on my card here, so I'm a pacifist, by the way. My first slide is up here. So I'm going to talk to you on how we image neuroendocrine tumors and what type of scans we have available. I'll cover a little bit about the risks of radiation, since that's obviously on a lot of people's mind. And then we'll go into how imaging helps in managing a disease, that is staging of neuroendocrine tumors, selecting patients for PRRT, and checking how effective the various treatments that we have available are. So how do we image NETs? So several modalities are available. We have anatomical imaging, which really shows us structures, how big things are, where they sit anatomically. And the main modalities for anatomical imaging are CT, MRI, and ultrasound. And then we have molecular imaging, which gives us information about how cells and tumors and the various structures in the body work, what their metabolism is, what kind of receptors they express. And then over the last 2 decades, the fused imaging has been developed, which sort of combines anatomical imaging and molecular imaging. And most of you have probably heard about SPECT-CT and PET-CT, and more recently PET-MRI, where we get a combination of structure and molecular information. I'm getting neck pain. I have to rearrange this here. Okay. So how does anatomical imaging work? Anatomical imaging uses mostly X-rays or magnetic fields, or ultrasound. And as I alluded to earlier, it images structures. In the example of X-rays or CAT scans, which also use X-rays, you have a machine that produces an X-ray. It's sent through the body, and then on the other side you have detectors that can pick up the X-rays that have been changed by traveling through the body. And then the detectors and the associated hardened software create an image, and the job of a radiologist is then to interpret these images and write a diagnostic report. This is an example of a CAT scan. This is a coronal view, looking at the patient from the front. You can see the heart here, you can see the liver. And then if you're a radiologist, you can pick up a big lesion here in the left liver lobe that indicates there's disease. Because of the depiction of the structure, I can tell exactly where this sits, how it relates to other organs that are close by. Molecular imaging uses radioactive tracers, and it allows us to see what is happening inside the body, the organs, and the cells on a molecular level. The tracers that we use for neuroendocrine tumors that target a receptor that's present on these tumors, the somatostatin receptor. So you have the neuroendocrine tumor here, you have the somatostatin receptor sitting here, you have a molecule called dotatate that binds to this receptor, and attached to this dotatate you have a radioactive isotope, gallium-68, that emits photons. We inject the tracer, it binds to the tumor, the gallium-68 emits the photons, and then we have a camera, a PET scanner that can pick up the radiation, and then again the softened hardware create an image that I can then interpret. So this is again a coronal view looking at the patient from the front, and you can see this big blob here of a lot of tracer uptake that indicates that there is a tumor sitting here that expresses a lot of somatostatin receptor and takes up the tracer. Now, fused imaging combines structural and functional information. And the examples, as I said, are SPECT-CT. The most frequently used is PET-CT, and a few places also offer PET-MRI. So now again, you have the same coronal view of the patient that I showed you before, but now we're combining the PET images and the CT images. We're overlaying them. We can see the anatomy, the structure. I can see this big blob here of a lot of tracer uptake. Because of the CT information, I can exactly say where this tracer uptake is taking place, and the intensity of the tracer uptake gives me information about how many somatostatin receptors this tumor expresses. Now, the risk of radiation is getting a lot of bad press, so I'm going to try to, since I work in nuclear medicine, I'm going to try to improve the reputation of radiation. So what are the most frequent patient concerns? The most frequent question, of course, is, will I glow in the dark? I'm still waiting for that to happen. But am I radioactive after I get the scan? No. The tracer has, first of all, we give a very small dose. The half-life of the tracer, that is the gallium-68, is about an hour. So by the time patients leave our department, most of the radioactivity will have decayed or left the body via the urine. Can I be around children or pregnant women after I had the scan? Yes, absolutely no problem. Can I eat anything I want? Yes, as long as it's healthy. And you're encouraged to drink more than usual on that day of the scan, not because of the radioactive tracer, but more because of the intravenous contrast that you get for the CT portion of the PET-CT. So what are the risks from radiation? If you look at these, the dose that you get from a dotatate PET-CT scan is about 2.5 rem. These are some of the statistical numbers that have been derived from the survivors of the atomic bomb attacks during the Second World War. And you can see that the risk increases, the relative risk increases with the increasing dose that patients receive. Now, if you look at the actual number here, it's very small, right? To put that into perspective, just by living on this planet, the amount of radiation that you receive depending on where you live, but for the United States, the average background radiation that you receive during a year is about 0.72 rems. To put it further into perspective, somebody such like myself works with radioactive isotopes. I'm allowed to receive 5 rems during the course of a year. So twice as much as what you receive from a scan. To put it further into perspective, the lifetime risk of developing cancer is 1 in 5, or 20%. So if you compare this number to the increase of risk that you get from radiation, this is really almost negligible. And then you have to put it even further into perspective, if you already have cancer, the information that you get from the scan is something really important to be able to give you the best possible treatment, so that theoretical small additional risk that you get from a scan is really negligible and shouldn't stop you from getting the scans that your doctor prescribes. Sold? Maybe, yes? Okay. So how does imaging help? First, I'm going to talk about staging and restaging. So when you get diagnosed with neuroendocrine tumor, you want to know how advanced the disease is. It can be such as in this patient, where you only have one area. The patient has a pulmonary neuroendocrine tumor. There's no evidence of metastatic disease. This patient can be cured with surgery. And here we have what we call an axial slice. This is the right lung, and you can see this tumor here that takes up a lot of the tracer, indicating where the tumor sits. Now, on the other hand, you can also, when you get diagnosed with a carcinoid tumor, this is a patient with an ileal carcinoid, at the time of diagnosis, the disease can already be advanced. So this patient is no longer a surgical candidate, but will need different types of treatment, systemic therapy probably. So that's why staging is important. The other main indication for doing the dotatate scans is selecting patients for PRT, which is an acronym for peptide radioreceptor therapy. As you remember, for imaging, we have the somatostatin receptor on the tumor, we have the dotatate that attaches to the receptor, and then we have a radioactive isotope that we can use for imaging. Now, in PRT, we have the same dotatate here that binds to the somatostatin receptor, but instead of labeling the dotatate with an isotope for imaging, we label it with an isotope that locally emits a different type of radiation that will kill the tumor cells. And the isotope that's now most commonly used is the 177 isotope of lutetium. So before deciding whether a patient should receive PRT, we'll do a dotatate scan. If the patient has a lot of uptake that indicates a high density of somatostatin receptor, this patient would be an excellent candidate for PRT. Then you get those patients where you do see some uptake, but most of the tumor doesn't express a significant amount of somatostatin receptors. The uptake is low grade. We usually use the liver as our cutoff. This patient is not an ideal candidate for PRT. And then some patients that have very aggressive neuroendocrine tumors, they do not express any somatostatin receptors, so you don't see any uptake, and these patients are definitely not candidates for PRT. So if we treat somebody, we want to know whether our treatment is effective or not. So how do we check effectiveness? Well, we can look at size. So if we have the tumor, we give treatment, and the tumor disappears. That's, of course, the ideal situation, and we know the treatment worked. If the tumor gets smaller, that's also indication that the treatment works. Sometimes the tumor stays the same. This can be a desirable outcome. We call that stable disease. Unfortunately, sometimes the tumor gets bigger or new metastases develop. The disease has progressed, so the treatment is not working. The patient's treatment has to be changed to something different. The treatment will also induce molecular changes. So if you have a neuroendocrine tumor, you have uptake of the dotatate, and then you treat the patient. If the tumor gets smaller, usually it also, because you're killing tumor cells, so that the amount of receptors present is going to be decreased. You'll see a decrease of dotatate uptake. Sometimes the tumor doesn't change in size, but it'll decrease in dotatate uptake. You've killed cells, not enough to make the tumor actually shrink, but you're killing cells and you're reducing the amount of receptors present on the tumor, decreased dotatate uptake. Sometimes you'll see increase in the size of the tumor and decrease of dotatate uptake. Now that can indicate that the neuroendocrine tumor has actually changed its characteristics, it's become more aggressive. So normally well-differentiated neuroendocrine tumors don't take up another tracer that we have available for imaging called FDG, which basically resembles a sugar molecule. Now, low-grade neuroendocrine tumors do not take up a lot of FDG, but if they become more aggressive, then FDG uptake will be increased. So if you have a tumor that increases in size but decreases in dotatate uptake, probably FDG should be used as the tracer for imaging of the tumor. Here's an example of a patient that had both types of tracer, both the dotatate and the FDG. And you can see that these lesions that don't express a lot of somatostatin receptors, don't take up a lot of dotatate. When you image the same tumors with FDG, you see a lot of uptake, indicating that this is a more aggressive neuroendocrine tumor. Dotatate scans have an impact on management. This was a study that we did at UCLA before it was FDA approved, that is the dotatate. And we looked at pre- and post-scan questionnaires, how the referring physician's suspicion of metastatic disease had changed based on the scan. That changed about a quarter of patients, and the dotatate imaging resulted in management changes in over half of the patients that we imaged. And then we followed up whether these changes were actually implemented, and most of the doctors actually acted on the information that the scan gave them. So in summary, so dotatate, or the commercial form that is now FDA approved called NetSpot, binds to somatostatin receptors that are present on neuroendocrine tumors. Why do we image? We want to stage the disease. After treatment, we want to restage to see whether the treatment is effective. And we want to identify suitable candidates for PRRT. When do we image? Initial staging is done when the disease is diagnosed, and then restaging is done after treatment. And with that, I thank you for listening.